Hello everyone. I've been a very warm welcome to one and all present here. Welcome to the International Society for Chronic Illnesses Annual Conference 2021-22. I'm Lalita Lavanya Shri, medical student from Ukraine. I'm a part of ISCI organizing team. It is a 2 days event. On day one, we had a panel discussion on medical student research mentorship and further prospects, which was yesterday. Today we have a PRMP poster presentation competition. It is a moment of great pleasure to welcome the delegates who are present here today to attend conference on day 2. On behalf of ISCI, I offer my regards to both the judges and people joining us. We are honored to have you all with us. So now let me give a small introduction about what is ISCI. The International Society for Chronic Illnesses is an effort which was made to unite healthcare workers from all around the world to improve the quality of life of people with chronic conditions. It was started in June 2021 in 2 nations with about 60 members and one active program. Over the last year, we are pleased to share with you that we have increased our reach to more than 15 nations with 650 plus members and 4 active programs. Today, the International Society for Chronic Illnesses is celebrating 1 year of its achievement in research, networking, and learning. On this special day, we have organized a poster presentation competition where our selected PRMP groups will be presenting their research papers in the form of posters. The competition will go on for the next 2 hours. Following this, we have a prize distribution ceremony for the winners of World TB Day 2022 competition, PRMP Awards, and then we'll finally announce the results of today's PRMP poster presentation. I would now like to welcome our judges. Dr. Vincent Kipkorer, Horns in Human Anatomy, Bachelor's of Surgery, MB-CHB, Medicine and Surgery. He works as a graduate teaching and research assistant in University of Nairobi, UON, in Department of Human Anatomy. He is an associate editor at International Journal of Medical Students, IJMS, editorial assistant and editorial intern at the Annals of African Surgery. He is also the reviewer board member of International Journal of Clinical Investigation and Case Reports. We welcome you, sir.
Thank you so much. Glad to be here.
Thank you, sir. Now, I would like a founder of ISCI, Dr. Purva, to take from here.
Hello, everybody. So, Vicky, could I share my screen, please? I'll continue. Just a moment, please. Okay. So, thank you, Lalita, for such a great introduction. I will, first of all, tell you all how you can get involved with ISCI if you wish to have any other role in addition to your current role. So, number one, you can join one of the ISCI teams, and I'll talk about all the teams later on in the next slide. Second, we are introducing new leadership positions, that's international and national heads of events and international and national heads of programs. So we, at the moment, as you know, we have 4 active programs. That's 2 are research-based programs and 2 are clinical programs. So we are going to accept applications for leadership in these programs. And then we have research leadership positions, that's head biostatistician and head of grant application. And last but not the least, a very interesting thing we are going to start at ISCI. We are going to launch the TRCCI program, that is Trainee-led Research Collaborative for Chronic Illnesses. Here, we are going to conduct multi-centric large-scale studies or longitudinal long-term studies, because we were able to create a trustworthy and skillful group of researchers who are spread in different countries. So if you have a research question in mind, if you know how to create a proposal, if you know how to get a study going, if you are a skilled researcher, then you can submit your proposal to the TRCCI program. And in addition to that, we will also be accepting applications if you wish to organize events, for example, like the World Tuberculosis Day 2022 event competition that we had earlier in March, and the current event that we are having, the annual conference. If you wish to organize any such events, then please contact us. Talking about projects, our latest project is the TB information portal, that's tuberculosis information portal. And you can check out our website if you want to know more about this project. If you have any project in mind and if you want to join ISCI and take help from our logistic team for this, then please let us know. Talking about the pillars of ISCI. So we have the PRMP, UM4CI, TRCCI, and the fourth LTCP program leadership. Then we have the ethics team. So the ethics team is responsible to have a look over for all the research work that is going on and keep in mind that the research ethics are being followed. Then we have the website managers, strategic advisors, social media team, data managers, facilitators, content writers, outreach team, and campus ambassadors. So this is what comprises the ISCI team, and we are always welcome to have new members. I would also like to share with you that due to unfortunate events, Dr. Gadad won't be able to join with us on the Zoom call, but she will be able to have a look at all the presentations on YouTube Live. There is a problem with the connection, and she said she's going to go through the recording and the question answer round with Dr. Vincent and the audience round that we are going to have, and she will give the marks later on after the event is over. So that is the information for today, and I would ask Lalita to take over from here. Thank you so much.
Thank you, Dr. Purva. I would now like to invite Mr. Aman Jawad to explain rules of competition.
Hello everyone, my name is Aman Javed and a very warm greeting to our esteemed judges. I was the chief organizer for this event, and I'll just go through the rules and format of this program. So first, talking about the rules for the poster presentation, abstracts were invited for the competition exclusively from the PRMP program involving the projects in the past 1 year of the program. After a careful evaluation of the submitted abstracts, a total of 11 abstracts were selected for today's presentation. The abstracts include original research articles, systematic reviews, meta-analysis, case reports, and case series. Now coming to the format of the presentation, each participant will give a brief introduction followed by their poster presentation. The presentation would be divided into 10 minutes, where 5 minutes would be for the presentation and 5 minutes for the question round. The question round would start with the questions by the judges, followed by questions from the audience, which would be presented by Ms. Kavya from the YouTube team. I would also like to add that the judges can ask questions for the first 3 minutes, and the remaining 2 minutes would be for the audience round. And results would be announced towards the end of the conference after tallying cumulative scores from the judges. Now, talking about the criteria for judging, we have total 4 criteria for judging, which is content, visual appeal, oral presentation, and overall impact. The content includes the appropriate components, whether careful thought was put in the poster contents, and whether the scientific content of the poster is accurate. Now, coming to visual appeal, that the components of the posters are balanced and the graphics are legible from a reasonable distance. In the oral presentations, the presenters should sufficiently explain the poster and answer the questions. They should speak clearly and they should show enthusiasm for the topic. And lastly, about the overall impact, many questions need to be answered, that whether the research has a potential to make a novel contribution, and does the presenter understand the importance of this potential contribution, and does the presenter indicate they understand how this research fits into the overall field. Additionally, I would like to add that Excel sheets have been shared with the judges so they can simply add the scores after each presentation. And if they face any issues, they can let us know. We would try to solve that. That's it. And I would like to hand it over to Ms. Lalota.
Thank you, Mr. Aman. I would now like to welcome our second judge, Dr. Bharati Kadar, PhD in Neuroscience. Dr. Bharati Kadar is an assistant professor in Department of Psychiatry, Texas Tech University Health Science Center, El Paso. She is also the co-director for the Southwest Brain Bank. Dr. Gadar completed her doctoral program in neuroscience in India. She did her postdoctoral training in a world-renowned laboratory at Institution for Cell Engineering, Department of Neuroscience at Johns Hopkins University School of Medicine for 3 years. Dr. Gadar is also the co-lead for the Youth Depression Childhood Trauma Research Network to Prevent Suicide. YDSNR and CTRN. Currently, these two projects are related to recruiting and screening adolescents with depression and childhood trauma in the US, Mexico border population of the Paso del Norte region. We welcome you, ma'am. Now, we shall begin with the poster presentation competition. I would now like to invite our first participant, Mr. Abhay Srivastav, to present this poster. While the presentation is going on, audience can put up their queries in YouTube chat box.
Hello. Hello, am I audible?
Yes, you're audible.
Okay, so hello, welcome everyone. So as a first participant of this poster competition, this is our abstract slide that I have submitted for this particular competition. So basically, it's just a preclinical studies done by the two eminent scientists, and so actually they are academic physicians and also working in this field for over 30 years. So these are Dr. Shenbag and Dr. Abbinder. So they explore the immunotherapy, diagnosis, and pathophysiological changes occur over the time of the Hodgkin lymphoma. What we did to this particular research to write a commentary on is to explore the topics and some points that are not included in the research paper. So first we started with the single drug chemotherapy regimens. This basically used in the early trials of the Hodgkin lymphoma when the patient going through the primary checkup and the follow-up, starting with the early trials, they have been suffer with some response rate of 45% with meclorethamine and chlorobutylcyl, and 57% of response rate from cyclophosphamide therapy. This is basically the conditions that occur to the patients while they are giving this treatment, and some of the progression-free survival rate and the overall survival rate compared to the transformation risk to the two therapies is two different single drug chemotherapies will be was around 15%, because the transformation risk of the first one comes up with 15% and another one is 20%. So the second one is found to be more lucrative than the first one. And then we explore the data, the study of the 3 cancer research centers. Here is the data. Here you can see the graph where I have mentioned all the 3 studies conducted by these eminent cancer research centers. They just explore the data unbesmirched and accurately by studying the patients in clinical trials. So they studied over 200 patients, basically in clinical trial phase 2. So they found the transformation risk about 40% in MD Cancer Research Center and 30% by British Columbia, and near about 16% by Mayo Clinic. So I also mentioned the overall survival rate of the patient in this cancer research center. But the one thing that I haven't mentioned here is the progression-free survival, which is also higher when the trials conducted by MD Cancer Research Center, but it reduces as the trial goes on. And lastly, the Mayo Clinic groups started this trial, and they come up with only 8% of transformation risk and only 40% of 76% of overall survival rate. So this shows the study of RCHOP, which is rituximab with the cyclophosphamide and doxorubicin, vincristine, and prednisone given to the patients of the non-Hodgkin lymphoma. They were supposed to have the response rate of this with the transformation risk, overall survival, and progression-free survival. And the third point, what we have explored is the survivor patients. They just go through the follow-ups and the checkups by observing the patients to a certain extent, where they have found the second malignancies formation in the patients. They were caused due to the treatment they were having in the past. For example, procalcitonin and alkylating chemotherapy and radiation, and some other immunotherapies they are getting. But these patients are cured, and also they have better life expectancy, but still at some point of the stage they are developing these second malignancies. And the second factor, they also are also caused with bipolar disorders and other mental illnesses because of the conditions and the neurotransmitters that are not releasing well and communicating because of the conditions arises due to the cancer sustained body. So after all of these, observing these points and just heading towards the exploration, we have found a significant change in the data that the Hodgkin lymphoma survivors were developed these conditions, but they have better life expectancy. They are curing from these treatments, and we never know what will the additional studies will coming through this project, and what are the other clinical trials that Dr. Shenbag and Dr. Abninda gonna add it, and we will like to contribute to this study and study to motivate more and more researchers to cure Hodgkin lymphoma patients. So in the future, when we just look at in the back and compare the data, we see that the patients of the Hodgkin lymphoma are reduced significantly and are cured well. Thank you very much. Hello.
Yeah, thank you. I would now like judges to ask questions to Mr. Abai.
Thank you so much for the presentation, Mr. Abe. As I even tried to again go through what you presented to us, excellent work. What I'd like to ask is when we think about the key conclusion of the findings of the present study, what will you comment about that?
I'm sorry, sir. I can't hear you properly. Your voice is cracking. What is the question exactly?
Apologies about that. Can you hear me now clearly?
No, I'm sorry. I can't hear you properly.
Okay. How about now?
Yeah. Now, okay. Sorry about that.
No worries. So my question is, if you'd comment on the key conclusion of your findings, what will you talk about, and maybe how the current study translates into the influence on future research, and what the path that it probably sets forth for incoming research on the same topic.
Well, concluding this all abstract and the commentary that we have just shared here, and I would like to explain 3 or 4 points, the question that you have asked me. For the future perspective, these immunotherapies that are used in the recent days of clinical trials are significantly reducing the cause of Hodgkin lymphoma. And basically, some of the therapies are introducing in the field of cancer research, where the 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 exploitation of the radiation and the other causes of uh, uh, radiation and the other chemotherapy regimens are not including in the part of the treatment, because as we just go for it, understanding the whole things at molecular level and understanding all the antigens and the pairing of these to block the receptors. So some of them are recently showing some significant changes. So as for the future aspect, I would like to see this research more focused on the immunotherapy and giving a drug intervention to the patients that will completely cure the patient and understand the cause of the cancer without going through the expensive prognostic tests and chemotherapy and other radiation therapies.
All right, thank you. Thank you for the response. Back to you.
Thank you, Dr. Vincent. Now I invite Kavya to read the first question in the chat box.
Hello, everyone. Still there are no questions.
So let's give 2 minutes to the audience to think of some questions and ask if they wish to. And remember, the audience round Q&A will also be marked. So it is important that the audience asks questions. All the participants who are here, they can also feel free to ask questions. Thank you.
Okay.
Kavya, can you please read the question?
Yeah, here goes the question. What can be the impact of your commentary articles on future studies?
Well, I already answered this question because Dr. Vincent asked me that our goal is to just update everyone about the Hodgkin lymphoma survival rates by treating the patient, giving the immunotherapy, by patients going through the chemotherapies and the other radiation therapies. We would like to see the patients who are not going for these expensive and dangerous therapies. Instead of that, giving drug interventions and curing it, understanding the cause of the Hodgkin lymphoma at molecular level. That's all our goal is.
Thank you, Abhay. Now let's move on to our second participant. I would now like to invite our second participant, Dr. Jill Makadia, to present her poster. I would request judges to start their evaluation process, and I would also request audience to put up your queries in the chat box while Dr. Jill is presenting. Thank you. Dr. Jill, you can start presenting your poster.
I don't think Dr. Jill is in the Zoom chat, so we can move to the next participant and come to Dr. Jill later.
Okay, so now I would like to invite our third participant, Miss Anaka Shri, to present her poster. So while presentation is going on, audience, you can put up your queries. I would request judges to start your evaluation process. Miss Anaka Shri, you can start presenting your poster.
Can I start? Hello, good evening.
Good evening. You can start your presentation.
Okay, good evening, everyone. My name is Anaka Shri, and I'm a third-year medical student studying at SGT Medical College and Research Institute, Gurgaon. And I'll be presenting my poster on the topic, Occurrence of Pruritic Urticarial Papules and Plaques of Pregnancy. So, pruritic urticarial papules and plaques of pregnancy, also commonly known as PUP, presents as a benign lesion on the abdomen, and it is a self-limiting inflammatory reaction that typically affects the women who have been pregnant for the first time. And this particularly occurs in the third trimester of pregnancy. So often in multiple pregnancies, like twin pregnancy or triplet pregnancy, there's an increased weight gain and increased distension of the abdominal skin, which leads to body's immunological response. Plus, the levels of sex hormones, they keep on changing in different trimesters. Both of these reasons together, they act as a possible triggering factor for the disease progression. And because of the rapid stretching of the skin, there is damage to the connective tissue in the abdomen, which leads to an inflammatory reaction, which further on leads to production of urticarial or hive-like lesions. Talking about the pathogenesis. So the risk factors for the occurrence of PUP include speedy excessive weight gain, which commonly occurs during multiple gestation, multiple pregnancies, especially when women are born with twins or triplets. And there is rapid stretching of the skin, which leads to conversion of antigenic molecules, non-antigenic molecules to antigenic molecules. And another reason is that there is increased vascular permeability. Due to this increased vascular permeability, the fetal cells, they migrate from the fetus to the mother's skin, which leads to an immunological reaction, especially in the third trimester of the pregnancy. The presence of fetal DNA in the mother's skin, it acts as an etiological determinant of the disease, and multiple gestations are linked with, also another factor is that multiple gestations are linked with increased levels of estrogen and progesterone. Progesterone happens to worsen this condition, and it leads to increased inflammatory activity at the level of the skin lesion. And it also increases the reactivity of progesterone receptors, which are found in the cutaneous lesions of PUP. Talking about the histopathological findings, there's presence of perivascular lymphohistocytic infiltrates of eosinophils and mononuclear cells, and accompanied with skin edema in the dermis. And presence of activated T cells indicates that there is a hypersensitivity type 4 reaction, also delayed type hypersensitivity reaction. Now coming to the clinical features of the disease, it is divided into 3 types. The morphology type 1 is 3 types of lesions. First is the urticarial lesions, then papules, which are less than 1 centimeter, and then we have plaques, which are raised, well demarcated lesions more than 1 centimeter in size. Talking about type 2 are discrete red colored erythematous patches, which are surrounded around the papules vesicles. They sort of form a cluster around these lesions. Type 3 is a mix of type 1 and type 2, and sometimes they're also seen in multiple gestation. Coming to the treatment, usually whenever a woman presents with such complaints, the conservative treatment would be to give antihistamines to prevent urticaria. It can be given orally, it can be given topically, and apart from that, we can also give steroids. It could be topical steroids or systemic steroids. But now more preferred treatment is cyclosporins, which is an immunosuppressant, which is used with infliximab, and this is considered to be first-line treatment for PUP. Coming to conclusion, so this study brings into focus about how the female body reacts during gestation, how the female body presents during gestational period. So there are multiple skin disorders which are broadly grouped under the category of dermatosis, out of which the most common disorder is PUP. And excessive weight gain, which occurs during multiple pregnancies, twin pregnancy or triplet pregnancy, is considered to be a risk factor. So the histopathological findings that I recently talked about, they help us come up with a better treatment option, not only to provide symptomatic relief, but also to provide effective therapy and prophylactic treatment. The complications that may arise due to this disorder are very rare, but they should be prevented as they may lead to maternal or fetal comorbidity. Thank you.
I would now like just to ask questions to Ms. Anaka.
Yes.
Thank you so much, Ms. Anaka. Just confirm if you can hear me audibly.
Yes, yes.
Okay. Great presentation and interesting topic. My question particularly is to inquire if along the course of your review, were you able to maybe find some data outlining anything on the prevalence of these lesions? And also in particular, you've described about type 1, type 2, and type 3. I don't know, particularly, were you able to also see if there's any literature available which would probably explain why one will have a type 1 versus a type 2 versus a type 3? Rather, what I'm asking is, are the types, do they have a pattern in terms of whom they present in? Yes, those are my 2 questions. Thank you.
Usually they're scattered lesions which are present symmetrically on the abdomen, and they're usually present in clusters. So the references that I've referred to, just one second, they tell us that they're present throughout the abdomen. So most common lesion is type 3, which is a combination of type 1 and type 2. We have urticaria, like urticarial lesions, plaques, and papules, which are distributed evenly throughout the abdominal stria.
All right. Thank you. Maybe the first bit of the question was just the overall prevalence of these lesions in multiple pregnancies. I don't know if you were able to maybe find any literature on that.
They're more common. So we found out literature which stated that these lesions are more common in multiple pregnancies because of the immunological reaction that takes place. Firstly, there is increased stretching of the skin when the weight increases, which leads to damage to the connective tissue, which further on exacerbates the inflammatory reaction. So there was literature which stated that multiple pregnancies, like, therefore I conclude by saying that multiple pregnancies increase the risk of PUP.
All right. Thank you. That's all from my end. Back to you.
Thank you, Dr. Vincent. Now I invite Kavya to read the first question in the chat box.
Yeah, here is the first question. What is the difference between a pup rash and pemphigoid gestationis, also known as PG? Which are the two different dermatoses of pregnancy?
Right. So PUP is different from pemphigoid, as in PUP we classically have only we have just 1 second. We have urticarial plaque. We have urticarial lesions. We have plaques and papules, but they're accompanied by pruritic. That is like itchy rashes, right? But in case of pemphigoid gestationitis, we have rashes which have more of blisters, and it's an autoimmune response. Whereas PUP does not have blisters, and it's not an autoimmune response.
Great. Let's have a second question.
Yeah. Here is the question. What is the difference between a scabies rash and pruritic urticarial rashes?
Can you repeat the question?
Yeah, like what is the difference between a scabies rash and a pruritic urticarial rash?
Scabies. Okay.
Scabies rash, yes.
I'm not really sure about this question. I'm sorry.
That's okay. Do we have any more questions?
No, you can continue.
Okay. Thank you, Anaka. Let's move on to our next participant. I would now like to invite our fourth participant, Dr. Binish Aslam, to present his poster. While the presentation is going on, audience can put their questions in YouTube chat box for the audience question and session round. And I would request judges to enter the marks in the judge sheet.
Good evening, everyone. I'm Binish Aslam, graduated from Jinnah and Medical University, Karachi, Pakistan in 2019. Today, I'm going to present my study under name Studies of Circulating Level of Ovarian Hormone in Women Having PCOS. Now, PCOS is the polycystic ovary syndrome, and it has been a serious issue in female. It is a state condition of ovary in which female hormones are imbalanced. Consequently, leads to the disturbance in menstrual cycle, skin changes, a small cyst in the ovary, and having trouble in getting pregnant. In European Journal of Endocrinology in 2009, published that vitamin D deficiency in the circulating level may be possible role in the infertility caused in women having PCOS. There are lots of studies done like Solomon 99, Pandan 2003, and so on. All these studies undertaken before has not reached the actual reason of PCOS. Now come towards the aim and objective of this study. The objective of present study was to evaluate the patient with PCOS and collect the scientific and endocrinological information about its real cause so that the patients suffer from these type of syndrome may be made aware of concrete and real cause of the occurrence of this disease. The material and methods are used. Stratified sampling technique has been used, and the patients, 11 patients, this study has been done, having age 18 to 40 years. It is the cross-sectional study, and the questionnaire has been generated. The ultrasonic study, hormonal study, and vitamin D lab test revealed that change in size of uterus and ovary. The reason behind the abnormal change in ovary size may be due to the highest level of luteinizing hormone in the serum of patient having PCOS. Increased level of luteinized hormone and decreased level of follicle-stimulating hormone may be cause of increase in ovary size. Cis patient uterus size normal, but ovary size increasing, while 5 patients having increase in uterus size as well as in ovary size. And all of these patients, their vitamin D level are decreasing. Conclusion of the study is that it is concluded that PCOS in women, hormone imbalance, follicle stimulating hormone, prolactin hormone, and thyroid stimulating hormone all these hormone imbalance may be occurred due to the deficiency of vitamin D. Deficiency of vitamin D may be probably due to the non-availability of vitamin D because most of the women avoiding sunshine, living in flats, and do not have a direct exposure to the sun. Maybe they do not intake the dietary source which are rich in vitamin. Thank you.
Now I would like judges to ask questions to Dr. Binish.
Thank you once again for the wonderful presentation. My first question will be particularly as regards to the methodology. What informed the sample size of 12? And then also when including the particular participants into the study, what probably was what was your exclusion criteria to avoid any elements of bias that you earlier on identified? And the third question will be, based on the conclusions that you've presented to us, what recommendations will you have to both in terms of the applicability of the findings of your study, as well as recommendations for future studies? Yes, that will be it from my end.
Actually, the exclusion criteria for this study is the all women having the menopause, reached to the menopause, are all excluded. And now, I think, can you repeat the question?
My initial question was what informed the sample size of 12?
Actually,
and then
the sample size, I use the sample size 12% to come towards to the confidence level 75% and the margin of error of 10%, because I use the sample size less small size because in earlier year the United States taking the study on 13 patients. So that's why I want to complete in the lesser time. That's why I took the sample size of 12 patients. Now come towards the conclusion. Actually, the exact cause are still unknown, and it might be. I just want to do this study because I just want to collect the real cause of the Pcos ovary syndrome. So that's why I might think that, and according to my conclusion, that all these patients have the decreased level of vitamin D. So it may be the cause of the hormonal imbalance, or it may be the cause of PCOS.
All right. Thank you for the response. Maybe just to try get an overall understanding of the burden of Pcos in the region of the study. What's the general prevalence of Pcos around the region where
my future research will also based on the prevalence of vitamin D level in PCOS. And I want to do this study on the larger sample.
All right, thank you. My initial inquiry was when you look at the prevalence of Pcos in the sample population, or rather the geographical region where the study was done, what's the general prevalence of Pcos?
Yes, of course. Now, the effect of deficiency of vitamin D, there are lots of side effects of deficiency of vitamin D, like they may reduce the level of estrogen, so that it may be the cause of stress and depression. And they also affect any other effect like osteoporosis. And deficiency of vitamin D
Okay, thank you. First,
can
I
lead
would
to the
thank
other
Dr.
diseases.
Vincent.
In children, it may cause the rickets. Any other?
Are there any other questions left, Kavya?
Yes, there is a question. Is there any association between the genetic factors and PCOS?
Yes, it may be. There is a lot of study done. Some said that genetic factor may be the cause of PCOS, but it not be sure.
We have another question for you. Like, if there is untreated PCOS, can it lead to the complete infertility of the women?
Can you please repeat the question?
I mean, like, if the PCOS is untreated, can it cause
Yes,
the women
of
to
course.
be infertile completely?
Yes. PCOS, if it untreated, it may lead to infertility, and the woman can become impotent.
Okay.
Because PCOS is very complicated disorder. It may lead to the diabetes, obesity, and lots of problems as well.
Are there any more questions?
No, you can continue.
Thank you, Dr. Benish. Let's move on
Thank
to our
you.
next participant. I would now like to invite our next participant, Dr. Jill Makadia, to present her poster. While the presentation is going on, audience, as usually, can put up your queries. I would request judges to start their evaluation process.
I'm sorry for interrupting. I hope the judges are not facing any problems in adding the marks and they are able to access the Excel sheet.
Yes, from my end, I have no challenges. I'm computing them on my end, and then I'll update the Excel sheet. Thank you.
Sure, thank you. Thank you. Vicky, can you please go to the second slide because Jill actually missed her poster. Thank you.
Hello everyone, good evening. I'm really sorry for missing it because I guess there was some issues with the internet. But yeah, hello everyone, I'm Dr. Jill Makadia and I'm in post-intern from Baroda Medical College, India. And I'm presenting a poster about jejunal atresia with a patent ductus arteriosus in a neonate. So jejunal atresia is a congenital obstruction of the small intestine, which is seen in the newborns, and it most commonly occurs due to the ischemic insults, which occurs during the pregnancy. And here I present a case of a jejunal atresia with a heart defect, patent ductus arteriosus. Moving forward with the case report, the case was of a 3-day-old boy, which was diagnosed with the dilation of the bowel loops on antenatal ultrasound. The boy was delivered via spontaneous vaginal delivery at 42 weeks gestation with a birth weight of 2.5 kgs. He presented to the hospital with a history of foul-smelling greenish vomiting, and since the birth, and he also had an abdominal distension with a failure of defecation and micturition. On admission, the postnatal ultrasound and X-rays were done, which, as shown in the figure, showed dilation of the small bowel loops, and fluid levels can also be seen here. Then the echocardiography was performed, which revealed patent ductus arteriosus, pulmonary atresia, atrioventricular and ventriculo-arterial discordance. So the patient underwent emergency explorative laparotomy, during which the constricted jejunum was resected and the jejunum anastomosis was performed. Further, the patient passed the feces on the second post-operative day, and the post-operative period was uneventful, and he was discharged a month later from the hospital. Jejunal atresia is one of the most common form of congenital intestinal obstruction. Prenatal diagnosis is uncommon in developing countries compared to the developed countries. and measures should be undertaken to facilitate the early diagnosis and treatment. Moving forward with the conclusion is that the resection of the constricted jejunal segment and a formation of a jejunal anastomosis is an effective post-operative treatment for the jejunal atresia. Thank you.
I would now like judges to ask questions to Jill.
Thank you so much, Dr. Jill, for the wonderful presentation. My question will be, when you look at the current presentations, do they share a common, maybe a common pathophysiological background, or rather an embryological basis that could probably explain the coexistence of the jejunal atresia and the patent ductus arteriosus? Maybe from your literature, are you able to comment on that?
Yeah, like I went through a lot of paperwork and all during this research thing, and I came across that, yeah, there is important, like, that ischemic insults which occurs during the pregnancy. It can lead to one of this congenital abnormalities which is seen. There were also I saw some cases also where it was embryological as well, like it went in generations also. So yeah, there is you can say connection between both.
Okay, thank you. That's it from my end.
Thank you, Dr. Vincent. Now I would like Kavya to read the first question on chat box.
Yeah, here goes the first question. Jejunal atresia in infants is a challenging problem. So what do you think is the best approach to tackle this problem from the prior literature review?
From my literature review, the most important thing to do is the diagnosis first. Like if antenatal ultrasound is available, then it's the best thing. Like you can see it beforehand also, so you can be completely prepared after the delivery of that baby that, okay, this can happen. And if it is not the case, antenatal ultrasound, then even after the baby is born, if possible, the diagnosis as soon as possible, if it occurs, then it is the best thing, because for this case, surgery is the only option we have. There are no medical treatment for this. So the diagnosis part is, if it is as soon as possible, it's the most important thing, and treatment as well. So if that's an important thing in this.
Great. Let's have a second question.
Yeah, it tells like how common is it to find both jejunal atresia and PDA in a single patient?
It is an extremely rare finding to have a jejunal atresia with an heart abnormalities or PDA. Because I have when I researched, I saw cases where the duodenal atresia cases were seen, but a case of jejunal atresia with a heart defect like PDA, it was rare. I couldn't find much cases on this. This case, there was duodenal atresia or other small intestinal obstructions, but yeah, it is a very rare finding to find both of them together.
Nice. Let's move on to our next question.
Yeah, there are no questions. You can continue.
Okay. Thank you, Jill. Let's move on to our next participant. Now I would like to invite our next participant, Dr. Bibek Timil Sinha, to present this poster. So while the presentation is going on, audience, you can put up your queries. I would request judges to start their evaluation process.
Thank you. Warm welcome to everyone to this. I'd like to thank ISCI and Prmp for giving me this opportunity of poster presentation. My name is Dr. Bibek Timil Sinha, and I'm a graduate student of Nepalese Army Institute of Health Science, and I graduated in year 2020. And today I would like to present a case of meningococcemia in an 11-month-old infant. So talking about the introduction part, meningococcal disease. It is, although a rare condition, it is caused by Neisseria meningitis, and it has high morbidity and mortality, especially moreover in children. It can present as a meningitis and meningococcemia. However, the meningococcemia is more the dangerous one. And herein we are reporting a case of meningococcemia without the features of meningitis in an 11-month-old infant, and he recovered following the treatment of antibiotics and supportive care. Talking about the case presentation, the child was 11 months old, and the child had high-grade fever, non-blanching purpuric rashes over the faces and limbs for 2 days. On presentation, on examination, his blood pressure was low for his age percentile, and was tachycardic with prolonged capillary fill time. However, there was no any signs of focal neurological deficits. The intervention and treatment was as follows: that the child was treated with IV fluids, bolus fluids, and along with intravenous paracetamol, along with antibiotics, ceftriaxone, vancomycin, and teicoplanin. Steroid was also initiated, along with vasopressor supports were required, and dopamine infusion, and also dovitamin infusion was required. Along with it, we required to transfuse packed red blood cell and fresh frozen plasma, and intravenous midazolam was given for the sedation, so that the child won't be moving and having so that we won't be having difficulty with treatment. He recovered after treatment with antibiotics and supportive care. On follow-up a week later from discharge, the child was playful and cooperative with no any systemic sequelae. On the discussion part, what I'd like to discuss is that meningococcemia needs to be diagnosed early and managed with antibiotic for treating infection, and fluid along with vasopressors for the management of shock. So about it, antibody against the capsule of the organism protect the infection, which forms the basis of vaccination against the most meningococcal diseases. Conjugate vaccination and polysaccharide meningococcal vaccine are currently available for vaccine for meningococcal diseases, and in children it's usually from we can provide vaccination from the age of 2 months. And as we can see in the figure, the purpuric rashes, usually it is 1 to 2 mm in size, but it coalesces and can present as such ecchymosis. And in figure 2, we can see that the rash has resolved after treatment. On conclusion, what I would like to say is, in a febrile and ill-looking child with non-blanching purpuric rashes in shock, the meningococcal disease should be suspected. Meningococcemia is more dangerous than the meningitis, so waiting for meningitis to level meningococcal disease might be harmful to the patient, and if the features of meningococcemia are seen, should be identified early and managed promptly. And I would like to also highlight the importance of meningococcal vaccination, which is the key to protection against the meningococcal diseases. I mentioned the references, and I'd like to thank all the participants and Shri Hospital, Department of Pediatrics, and the entire ISCI, as well as the sub-Prmp family, and the scholars whose articles and books were cited. Thank you. And questions and queries are highly welcomed.
I would now like judges to ask questions to Vivek.
Thank you so much for the wonderful presentation. My inquiry will be from the history that you gathered from the guardians or the parents of the infant. Were you able to determine an exposure status that will probably be responsible for the present presentation? And then the second bit will be, you've mentioned or highlighted the importance of a high index of suspicion of meningococcemia in such a presentation. And you've also mentioned the importance of meningococcal vaccination. perhaps from your literature, are you able to maybe comment on the uptake of meningococcal vaccine and maybe any barriers that hinder its uptake? And then also from literature, have you encountered any other case reports that are of a similar presentation to the one that you hereby present to us? Those are my 3 questions.
Thank you, Dr. Benson. About the first one, how it could be related to the case presentation. As it is a military hospital, so we could not exactly find the actual link to the transmission of the disease condition. However, the child could have been exposed to any of the military personnel or in such conditions, or maybe in some child play group, but however, we could not find the actual link for that one. And for the second question, could you, I guess, you asked me about the meningococcal vaccination. So in our country, in Nepal, what the current national immunization schedule, the protocol does not have meningococcal vaccination as such, mandatory to everyone. And yes, was I able to address your questions?
Yes, maybe the last one was, while you are looking through literature, were you able to encounter similar case reports to the one that you present here?
Oh, yes. Okay. So about that, about the similar case presentation, I could not find out this exact one, but however, there were many cases such as what we could find the literature was that under the case surveillance done in France, I guess there were around 150 cases reported in an interval of 5 years of time. But I guess I am not able to currently say you the details about those conditions. Sorry for that.
Thank you so much for the response.
Thank you, Doctor.
Thank you, Dr. Vincent. Now I invite Kavya to read the first question in the chat box.
Yeah, was there any contact history in this meningococcal patient?
Yes, as I have mentioned, thank you for the question. As I have mentioned, that we could not exactly trace out the transmission of the bacteria to the patient. However, his parents, being a military person, could have been exposed in any of the situation in the dorm or in the barracks. So I guess we need to look into it more.
Great. Let's have a second question.
Yeah, what people are at special risk for meningococcal disease?
Okay, and that's also a good question. Usually the young adolescent people, they are usually at the risk of meningococcal. However, in children, it is less likely to be. They are less likely to suffer from meningococcal as such. The likely causes could be transmission in the crowded places, such as in our dormitory, the teenagers, young teens going into large school, colleges. Such thing could lead to transmission of the meningococcal.
Let's have a next question.
Yeah, next question is do you think it is necessary to screen contacts of this child to prevent a large outbreak in the community that your hospital serves?
Okay. Yes, it is necessary so that we could prevent the transmission. However, during the course of treatment for about more than a week, the contacts were traced, but no one was the known contacts were traced, but no any person showed the signs and symptoms as such. Was I able to address the question?
Yes, the time for the audience round is over. Thank you, Dr. Bibek. Let's break this monotony and have a 5 minutes break. See you after recess.
Okay, thank you.
Welcome back, everyone. Let's begin with our poster presentation. I would now like to invite our next participant, Dr. Binaya Dakal, to present her poster. While the presentation is going on, audience, you can put up your queries, and I would request the judges to enter the marks in the judge sheet.
Okay, thank you, Lalita. Good evening, everyone, from all the way from the Nepal. I am Dr. Binay Dakal, a recent graduate from Nepalese Army Institute of Health Sciences here in Nepal. Okay, before starting my presentation, first of all, I'd like to congratulate all the members of International Society of Chronic Illness for the successful 1 year since establishment. Happy anniversary, ISCI. Here I'm going to present the case of abdominal. Okay, sorry, I cannot access my presentation. Sorry for that. Okay, I can do it. Okay, I'm going to present the case of abdominal tuberculosis that initially misguided the assessment, which was a case of Budd-Chiari syndrome, and it is a particular case in the tubercular endemic country like Nepal and any of the South Asian countries. Moving forward with the introduction part, Budd-Chiari syndrome is an uncommon disease due to the obstruction of hepatic venous outflow. The hepatic venous outflow that causes the congestion of the liver. The clinical manifestation ranges from the asymptomatic case, and that those requiring to the liver transplant, that is typical of our case here. And the main highlight of this case is that the importance of diagnosing a case of the Budd-Chiari syndrome, which has been suspected with the abdominal tuberculosis, and the anti-tubercular drugs were initially started that may further damage the liver. And moving with the case presentation, this is a case of an 18-year-old female who initially present with the abdominal pain following the recurrent abdominal distension, jaundice, and deranged liver function. And on investigation, it was found that adenosine deaminase, that is ADA level, was raised in both pleural and peritoneal fluids. Pertaining to this report, anti-tubercular treatment was started because the tuberculosis is very common in the countries like South Asian countries like Nepal and India as well. Since the start with the anti-tubercular treatment, the patient developed the adverse reaction to the drugs, and it could no longer be continued. And the patient status later deteriorated further, and it was followed by CT scan, which later revealed further suggestive of the Budd-Chiari syndrome. And initially, she was managed with the balloon angioplasty, but her condition further got worsened, and ultimately, patient underwent a liver transplantation. So here I like to highlight that Budd-Chiari syndrome can present a very subtle presentation, since abdominal tuberculosis is very non-specific, and the two conditions, that is abdominal tuberculosis and Budd-Chiari syndrome, can be very confusing, particularly in the tubercular endemic region. The early recognition is very necessary, as both conditions are associated with the high morbidity and mortality if not treated timely. Therefore, detailed clinical assessment along with the proper investigation and imaging should always be performed if any patient presents with the feature suggestive of abdominal tuberculosis. We should not be limited to the tubercular diagnosis. Finally, I'd like to move to my conclusion part. The necessity of the careful investigation and consideration of the Budd-Chiari syndrome as an important cause of the ascites with the jaundice and deranged liver function tests in the TB endemic regions, along with early anticipation of the liver transplant, is necessary, as I presented in this case. And that comes to the end of my presentation. Any questions are highly appreciated. Thank you.
I would now like judges to ask the questions.
Thank you for the presentation, Dr. Binay. My inquiry would probably be to ask on, you've mentioned that the anti-tubercular treatment wasn't able to be continued due to the adverse reaction. Later on, was the patient put on a different regimen of medication, or the anti-tubercular treatment was just ceased? Then secondly, are there common risk factors, or maybe something that will give us some sense of a pattern or a predictive score that would maybe help in predicting the occurrence of bad Chiari in abdominal tuberculosis, or they are coexistent together? So basically what I'm just trying to ask is, how common is this occurrence, or is this, from your literature rather, is this the index case that you've found and none exist in literature as at now?
Okay, thank you for the question, sir. I like to first address the first question. Initially, pertaining to the report of the high ADA level in both pleural and the peritoneal fluids, patient was studied with the anti-tubercular regimen. But as we initially failed in the diagnosis, because patient was initially suffering from the Budd-Chiari syndrome, but she was made a wrong diagnosis, and her liver was already in state of a state of damage. So anti-tubercular drug further caused the liver not to function appropriately. So we saw a further damage to the liver, and the liver function got more deranged. So the anti-tubercular drug was completely seized. And so as the diagnosis was not established at that moment of time, she underwent further treatment to establish the diagnosis. And then later the CT confirmed the diagnosis of the Budd-Chiari syndrome. And moving forward to the next question, the Budd-Chiari syndrome is very a rare condition. And I think you were asking about the possible causes, right? Am I right, sir?
Yes, so maybe just trying to zero in on the possible risk factors that will give rise to the presentation that you have given us today.
Okay, thank you, sir. In my particular patient, the exact cause was not able to establish because by the time a patient was diagnosed with the Budd-Chiari syndrome, it was too late, and all the tests that was done prior was all the tests that was done prior was all the negatives. So exact cause was not established, but possible cause of the Budd-Chiari syndrome may be like hematological disorders. It can be maybe due to the chronic infection, or maybe it may be due to the chronic inflammatory diseases, or it may be also due to the tumors compressing the vessels. That is what I am able to answer the question, sir.
All right, thank you. Back to the team.
Yes, thank you, sir.
Thank you, Dr. Vincent. Now I invite Kavya to read the first question in the chat box.
Yeah, here is the first question. What do you think is the best algorithm to diagnose abdominal tuberculosis, as it mimics many diseases?
Okay, pertaining to the specific to the abdominal tuberculosis, if any patient comes with the feature suggestive of abdominal tuberculosis, then patient most likely present with the features like ascites, jaundice, and many more. And at this time, the ascitic fluid analysis may be very helpful, like peritoneal fluid analysis can be done, and the cause can be established. Yes, thank you.
Great. Let's move on to the second question.
What investigation do you propose to distinguish between abdominal TB and Budd-Chiari in earlier stages?
Thank you for the question. This is the main highlight of my case. So, if any patients present with the feature suggestive of both abdominal tuberculosis and the Budd-Chiari syndrome, we should always have in background that this is without further investigation, we should not directly jump into the treatment part. So if the ADA level is high, that is not the only highlight that suggests the abdominal tuberculosis. So here CT scan can be a very helpful in diagnosing the Budd-Chiari syndrome. So because whenever we suspect, whenever we see ascites or jaundice, and particularly in the endemic countries like Nepal, we particularly think of tuberculosis, and we never jump to a radiology part like CT scan and ultrasound, right? And that may be a clue to a diagnosis to a Budd-Chiari syndrome, and we can differentiate it from a tuberculosis from Budd-Chiari syndrome. Thank you.
The time for the audience round is over. Thank you, Dr. Binaya. Let's move on to our next participant. I would now like to invite our next participant, Dr. Saurabh Karki, to present the poster. While the presentation is going on, audience can start asking questions as soon as the participant starts presenting their poster. I would also request judges to enter the marks in the judge sheet.
Good evening, everyone from Nepal. I'm Dr. Saurabh Karki, I'm a graduate from NIHS, and I'm going to present my poster in scrub typhus in a primary healthcare center of Nepal. So scrub typhus is a mite-borne disease caused by gram-negative obligate intracellular organism, that is Orencia susugamusi, and it's transmitted by the bite of larvae of Tromicumid mites. The bacteria tends to multiply at the site of bite with formation of scar, which is a characteristic necrotic lesion. It is one of the emerging infectious cause of acute febrile illness in Southeast Asian countries, including Nepal. Other symptoms of this disease can include like fever, headaches, myalgia, which are themselves non-specific in terms of presentation. Also, owing to lack of diagnostic tools in country like Nepal, the disease remains largely undiagnosed. Thus, through this case series, we would like to highlight the recent outbreak of case of scrub typhus in primary healthcare that occurred in Nepal. So now moving to methodology, this was a retrospective case series that described epidemiological, clinical features and outcomes among 23 patients admitted to the primary healthcare center between August and September 2021. And the diagnosis of scrub typhus was done as per evaluation of scar and by using the RDT kit, rapid diagnostic test kit. And we had used some of the operational definition during our case series, like we denoted anemia when hemoglobin was less than 10 gram per deciliter. Similarly, leukocytosis if WBC count was greater than 12,000, and thrombocytopenia if platelet counts was less than 1,50,000. And as for results, so from the case series, we could find that out of 23 patients admitted to the primary healthcare center, around 78% were of age group 20 to 60. That was the most common age group. And regarding sex, 47% were males. And regarding symptoms, fever was reported by all the patients. And there were other symptoms like headache, cough, and scar that developed among 65%, 43%, and 8% respectively. All patients were diagnosed by rapid diagnostic kit. So all tested positive in that kit, and 95% had complete recovery, whereas one patient was referred to higher center as he developed complication during his hospital stay. Coming to the conclusions. From this study, we would like to conclude that patient can present with fever and scar regarding for a scrub typhus. Then we should always have a high index of suspicion for scrub typhus, though scar may not be present in all the cases. Similarly, early diagnosis and prompt treatment with antibiotics is always the key to the disease entirety, as it can show a good response to treatment while preventing potentially fatal complications. In our case, we had used doxycycline. And similarly, during ongoing pandemic that had gone just, that has not been completely over, but in times of pandemic of COVID-19, while trying to rule out COVID-19, scrub typhus can definitely be missed easily. So there should always be suspicion, and it can always have a wide range of clinical features. Thank you so much.
I would now like Judge to ask question to Saurabh.
Again, thank you so much for the wonderful presentation. I have three particular questions. The first question is, you present a case series of 23 patients. My question is, did you note any common risk factors that probably the 23 patients had that predisposed them to the condition? Number two is, you've mentioned that of the 23, one of them developed complications. From the study that you did, inclusive of all the variables that you collected from the patients, are there any predictive markers that can predict whether one person who's contracted scrub typhus would undergo a complication or not? Basically, what are the risk factors towards a complicated case? And then the last thing is, you've mentioned that it's common for, especially during the COVID-19 pandemic, for underdiagnosis of scrub typhus due to its commonality of presentation with scrub typhus. So my question is, apart from COVID-19, what are the other more common conditions within your region, in this case, I think Nepal, that present similarly to scrub typhus that could be misdiagnosed in that case? Thank you.
Thank you, sir, for your question, sir. Since you have asked three questions, I really found a bit difficulty in following you, but I will try to address my questions as your questions as far as possible. So there was one case who had complications. So he developed septic shock and he required ventilatory support, and he was thus it was done in a primary healthcare setting, in a rural setting. So we did not have that facility, so we had to refer that patient to higher center. So the patient had a comorbidity. He had diabetes mellitus, and he was particularly old age. So any patient with old age and having immunosuppressed status can always predispose a patient to have a severe form of infections. Similarly, there could be markers like we could have by simple tests like leukocytosis and looking at the platelet count. These tests can just say that we can get about the patient, but we cannot say whether it's serious or not. And we will require other, like for sepsis, we might require like procalcitonin, and these facilities were not available at the rural setup, so we could not get into those facility. And regarding other question, I could not get it, sir. I was unable to follow it, so can you please repeat it?
Thank you for the first response. My question was, what are the common risk factors that the patients within your case series had that will probably have predisposed them to scrub typhus? Then the other thing is, what are the other conditions that can commonly be misdiagnosed for scrub typhus, apart from COVID-19 that you've just mentioned?
Well, sir, thank you for your question. So regarding the risk factor, so it could be like a host factor. The patient could have a disease like hello. So patient risk factors, like there were patients with old age of the patients, and some patients were having comorbidities like diabetes mellitus, hypertension. And similarly, we can also look at the environmental factors, since the case had been reported at August to September. This was the time where our case has also been reported at the past during the time of the deadly earthquake in 2015, and there had been a lot of cases at that time also. So this is the time where the animals like the rats and these animals tends to come out, and so this can help in spread of disease. And sir, your final question, sir?
My final question was the common conditions that are commonly misdiagnosed for scrub typhus.
This scrub typhus tends to present with fever, myalgia, and respiratory symptoms, so it can definitely be confused with conditions like influenza. It can also be confused with COVID-19, that pandemic, and it can there are other conditions like leptospirosis and malaria. So these are the conditions that and even enteric fever that's so prevalent in our country, and these are the conditions that we can be confused with.
All right, thank you. That's it from my end.
Thank you, Dr. Vincent. Now I invite Kavya to read the first question in the chat box.
Yeah, here goes the first question. WHO reports scrub typhus is probably one of the most underdiagnosed and underreported febrile illnesses requiring hospitalization. Can you please elaborate why this is the case?
Yes, and this is thank you for the question. And so I had previously mentioned about our condition in like in Nepal. In 2015, there was a mega earthquake, and there was a lot of life. There was lots of life that had gone, and massive destruction and huge economic loss following upsurge of such. There was upsurge in febrile illness, and at that time, the patient, the hospital tends to treat the febrile illness with drugs like cefixime, ceftriaxone as the first choice, and since this organism being an atypical organism, this ceftriaxone usually they are intrinsically resistant to these antibiotics, as this is our first choice in our hospital, and so the disease tends to be easily be undertreated. Similarly, there are no definite lab tests, and the diagnosis is mainly clinical. And what we have been trying to show from this case series is that ISCI is very high. It has high sensitivity for diagnosis of scrub typhus. However, the patient presenting with ISCI, the number of patients presenting with ISCI is very few. So it definitely poses challenges. So it tends to be undertreated as per WHO. I hope.
Great. Let's move on to the second question.
Yeah. How will you treat scrub typhus in deoxycycline deficit center?
So doxycycline and tetracycline, they are one of the pioneer antibiotic that had been preferred for scrub typhus. So the first pioneer antibiotic was chloramphenicol, and later azithromycin, rifampicin. These are other antibiotics that can be used. Similarly, there is levofloxacin that can be used in case of scrub typhus. But levofloxacin, if we use in severe case, then it definitely tends to do more harm over good. So these are the other choices we can go for.
The time for the audience round is over. Thank you, Dr. Saurabh Karki. Let's move on to our next participant. I would now like to invite our next participant, Dr. Hemant Reddy, to present the poster. While the presentation is going on, audience, you can put up your queries in the chat box. I would request judges to start the evaluation process.
Hello, am I audible?
Yes.
Okay. So, ladies and gentlemen, a very good evening to all of you. My name is Hemant Reddy Sanjamala. I'm a recent graduate of Bangalore Medical College and Research Institute. My poster topic is Novel Targeted Therapies in Triple-Negative Breast Cancer, a Systematic Literature Review. So, breast cancer is one of the most commonly occurring cancers in the female population worldwide. And triple-negative breast cancer is a particular subset of breast cancers that is characterized by lack of expressivity in estrogen receptors, progesterone, and HER2 receptors. So that being said, it is associated with bad prognosis in the sense that there is increased incidence of relapse and increased presentation of metastatic disease. Now, as a result, standard treatment modalities that are used in non-TNBC cancers are not really effective in TNBC. So as a result, a lot of targeted therapies are being developed for the treatment of TNBC. Targeted therapies are therapies which target specific molecules that is responsible for the proliferation of cells or in the pathogenesis of the disease. Now, as a part of methodology, what we did was we did a systematic review of literature to identify and study the available data on different therapeutic options that are used as novel targeted therapies for TNBC. Now, the sources that we used were PubMed, Cochrane, and Embas. Now, when we used these resources, we got about 454 studies and 32 additional studies from additional sources. Now, we applied inclusion criteria and exclusion criteria to this, and we ended up with 19 studies in the final review. As you can see, the flowchart over here, the Prisma flowchart demonstrates how we ended up with 19 studies. Now, the inclusion criteria for this case was patients with TNBC disease or recurrence, cases in which targeted therapy was used as treatment, and studies in between January 1st, 2005 to August 30, 2020, and studies in where the drugs are in different clinical trials in any phase of the study, and studies that are published in English language. Now, when we come to the results, in our review, as you can see from the graph, out of the 19 studies that we did, 17 studies show that there is the novel targeted therapies are significantly effective in treating the TNBC by reducing the morbidity and mortality, while two showing some negative results, amongst which one of them suggested additional research, and the other showed ramucirumab and eribulin does not significantly improve the outcome. Now, due to the limitations of the poster size, we could not include all the significant findings amongst the studies. So I would like to highlight a few points from the studies that we have done. So firstly, most of the studies show that a combination of chemotherapeutic options produces a much superior outcome than compared to an individual single drug therapy. One good example for this is platinum-based therapy in combination with paclitaxel have shown higher rates of pathological complete response. And capecitabine in specific has shown improved outcome in residual disease in post-neoadjuvant chemotherapeutic patients. And therapies that are targeting STAT3 have also showed improved outcomes. And one interesting point that we found in the studies is therapies that are targeting the checkpoint inhibitors. In the sense, the therapies targeting the program PD1 and PDL1, especially atezolizumab and avelumab, which are PDL1, which targets the PDL1. So it was found that PDL1 is associated with increased instance of, it is associated if PDL1 positivity was detected in a TNBC patient, it was associated with the worst outcome. So that gives rise to potential of PDL1 being a biological prognostic biological marker. And AKT inhibitors such as ipatasertib with paclitaxel, they have shown effectiveness, but no progression benefit over in low PTN tumors. Well, 17 studies of 19 were effective in improving the median survival and outcomes of the patients. However, they were associated with their own set of disadvantages. Now, as a way of conclusion, I would like to say that the availability of new and improved targeted therapies has shown improvement, thus reducing morbidity and mortality. But further research is still required in this field to further evaluate these drugs, to evaluate the long-term efficacy, and to assess and to make them more efficacious in the future. Finally, I would also like to conclude the paper by saying that if these therapies are made easily available, more accessible at an affordable rate in a community setting or an individual setting, it might invariably change the way we look at TNBC right now. Thank you very much.
I would now like judges to ask question to Hemant.
Thank you for the wonderful presentation. My questions will largely be under the methodology. Interesting findings you present. I'd like to know what were the search terms that you employed for the present study. That's my first question. And probably, as you mentioned about the search terms, you'd probably inform us also about what were your primary or secondary outcomes while you're designing the protocol for the systematic review. That's my first question. My second question, again, still under the methodology, is you described that the search strategy extended backwards to 2005, was there a reason behind the date 2005, or did you use that to define novelty? Because here you're looking at novel targeted therapies. So what's the definition of novel in this case? Is it novel as regards to the approach, or novel as regards to the timeline? So maybe you could comment on that. And then the other question is about, were you able to probably do an assessment of quality analysis to maybe try and see what elements of bias are present in the studies that you used to form the summaries in this study? I ask this because I'm hoping that you're able to employ the PRISMA guidelines in development of the systematic review that you hereby present. So those are my 3 or 4 questions. I don't know if that's clear.
Thank you, Dr. Vincent, for the questions. Yes. Yes. So answering your first questions, the terms that we used was triple negative breast cancer, and specifically we focused on locally advanced breast cancer, inoperable cancers, and metastatic diseases. So that helped us in excluding a lot of studies. And after that, once we were able to include apply the inclusion criteria and exclusion criteria specifically, we found a lot of studies that showed different kind of data and outcomes, but we tried to stay on topic and find studies that are relevant to our focus of study. So that is how we were able to come down to the different studies using the PRISMA guidelines, and that's how we ended up with this 19 studies in the final review. Now, second question, novel targeted therapies. Novel targeted therapies, frankly speaking, I do not know the exact answer to that question. So from what I have learned from my research and from my knowledge, is novel targeted therapies is it is said novel because of its approach rather than the timeline. So the January 1st, 2005 was picked as a random date. There was no strong intention or any analysis before we took that date. And it is novel in the sense that these are targeting, because now, as we know, most of the ER/PR positive or HER2 positive, for example, trastuzumab based therapies are used for this for HER2 cancers. Now, such established treatment is not really available for the TNBCs. Now, TNBC, now the big limitation is trying to find out what molecules are involved in its pathogenesis, trying to target that specific molecules. Now, for example, PDL1 is one thing that we found, and that is a good biological marker and also a good target for therapy. And similarly, mTOR, STAT3, and they also found SRC. So probably because of the type of approach, it's called novel targeted therapies. And sorry, what was the third question? I could not follow.
Thank you for that response. My third question was about whether you were able to perform an assessment of quality analysis for the studies that you included in the review. So ideally identifying, or rather scoring the studies using an objectified scoring system to determine whether there were any elements of bias in the papers that you've used to describe the literature review.
Okay, thank you. Yes, so there is bias in the findings in the papers as such, because the most of the studies or most of the data that's available right now is from the developed nations such as the USA and UK. And as we try to obtain data and collect data from the low income or developing countries, we could not find a substantial amount of data. So there is a kind of selection bias in the type of studies that were undertaken. At the same time, all of these studies are retrospective studies. So that will invariably lead to a selection bias in taking the number of the type of study or the number of studies that we have taken. And also a lot of these papers have given up the have the protocols that were in place in these studies and also the findings, the way they were reported, they're not homogeneous in any approach. The approach is not very homogeneous. So that also creates a kind of bias in the findings of this paper.
All right, thank you for the response. So maybe a comment, even as you move forward to publishing your findings, one thing you could probably look at is if you can find a tool that you can use to objectively score each of the papers. For instance, for anatomical studies, we use something called the Aqua tool. It's just the assessment of quality analysis of anatomical studies. So there are a couple of tools that you can probably employ so that even as we are interpreting the findings of your systematic review, we're doing them with a disclaimer of the overall percentage of bias in each of those papers. So maybe you can just look into the available tools for the same. Others, that's it from my end.
Okay, thank you for the advice. I'll definitely keep that in mind.
Thank you, Dr. Vincent. Now I invite Kavya to read the first question in the chat box.
Yeah, here goes the first question. What would be the difference in treatment of hormone receptor negative and triple negative breast cancer according to your research?
So hormone receptor, so as such, so since it's three receptors are in place, ER, PR, and HER2/neu. So in ER, PR negative and HER2/neu positive, as we know, trastuzumab-based therapy is in place and has shown very good effectivity. Now, when it comes to triple negative breast cancer, frankly speaking, any cancer society in place right now, the fulcrum of the therapy is chemotherapy, that is anthracycline or taxane-based chemotherapy, that is usually used in the neoadjuvant chemotherapy setting. So that is still, the chemotherapy is still the mainline treatment for TNBC. And so that is the reason the way we are looking at TNBC is very limited right now. And that is the reason we are looking for more targeted therapies that are targeting specific molecule. When we look at the other type of cancers, established treatments are already in place, and also surgery and radiotherapy also play a pretty good role in non-TNBC cancers. While in TNBC, surgery and radiotherapy, they do not play any extensive role or any significant role when compared to the non-TNBC. So right now the focus is still on advancing the chemotherapy and finding new treatments when we're treating the TNBC.
Great. Let's move on to our second question.
Yeah, it tells like, how do you explain the stage of the breast cancer by observing the Encode type diagnostic score?
Okay, staging of TNBC and non-TNBC are done in the same format as of my knowledge. The immunohistological analysis that we do for these kind of cancers is only done to approach them in a different way. It's only for the purpose of treatment. As such, the staging is done in the same way for both triple negative breast cancer or the non-triple negative breast cancer.
Nice. The time for the audience round is over. Thank you, Hemant. Let's move on to our next participant. Now, I'd like to invite our next participant, Dr. Kajal Patel, to present the poster. While the presentation is going on, audience, you can put up your queries. I would request judges to start your evaluation.
Hello everyone, I am Kajal Patel from Medical College Baroda, India. I am here to present my poster, Care for the Nature or Cure from the Nature, a review on metabolic syndrome. Metabolic syndrome is a pathological condition which is characterized by abdominal obesity, insulin resistance, hypertension, and hyperlipidemia. In the year 2020, the prevalence of metabolic syndrome was found to be more than 30% in India. And due to its increasing prevalence, it is important to use an integrative and holistic management approach in addition to conventional management paradigms. This article attempts to review the most relevant literature on integrative management of metabolic syndrome, including traditional Western medicine. We explored studies discussing the effect of mind-body, diet, supplements, religion, and faith in managing metabolic syndrome. Integrative medicine and health rises over the traditional mainstream Western medicine, focusing on psychological, physical, and emotional aspects of attaining wellness and restoring the underlying balance. Our objective is incorporating the mainstream Western and non-mainstream traditional Eastern medicine that proved to be more successful than the other treatment strategies discovered. Hence, our article is a literature review on the integrative management of metabolic syndrome with an updated discussion on the successful interventions practiced across the globe. We performed a Boolean search to find the literature in PubMed, Embase, clinicaltrials.gov, and Cochrane, and included freely accessible full articles, original studies, randomized controlled trials, and excluded all papers on reviews, editorials, commentaries, case reports, and case series. Among the mind and body therapies, the most successful interventions were meditation, traditional Chinese exercise, Tai Chi, yoga, Kapalbhati pranayam, acupuncture, and auriculotherapy. Among the diet and supplements, we found that intermittent fasting and caloric restriction, Mediterranean diet, alcohol, probiotics, trace elements, Chinese herbs and condiments, turmeric, bay leaf, basil were the most successful ones. In faith and religion, diabetes prevention program, which was a community-based faith-adapted lifestyle, decreased the prevalence of metabolic syndrome. Ramadan fasting, Bigo, which is a Chinese water-only fasting, and motivational interviewing proved to be decreasing the prevalence of metabolic syndrome. Integrative medicine and health is a productive approach in the management of metabolic syndrome, and we attempt to highlight the updated Western and Eastern interventions and recommend a summarized integrative approach to minister the metabolic syndrome wholly. Thank you.
I would now like judges to ask questions to Kajal.
Thank you for the wonderful presentation. My first question will be, we're looking here at the integrative management of metabolic syndrome. And so maybe an inquiry on whether this, you're able to come across literature that presents probably the percentage prevalence of individuals who are using this, I'll probably call them non-conventional means to manage metabolic syndrome. So do we have data on the current percentage prevalence and probably the degree of uptake of all these measures that you present? Secondly, when you look at the present study that you're presenting, are there any limitations that you probably would highlight so that even as we are interpreting your findings, we have the limitations in mind? I think those are my two questions for now.
Thank you, Dr. Vincent. The answer to the first question, during our literature search, we came across studies on integrative management, which were more about comparing the conventional management and the combination of integrative management with allopathy. I'm not so sure about the prevalence of the usage of such alternative approach. Okay, the second question, there were, okay, so while we conducted the search, there were some studies with good p-values, which showed good evidence. The strength of evidence was good, and there were some studies with very little population group. So That was one limitation. Another limitation was in traditional Chinese medicines, there is very little awareness about the side effects of the medicines. It comes with a lot of adulterations and impurities with the trace elements and is nephrotoxic and hepatotoxic. So in recommending such treatment option, it is very difficult to recommend such management. And the limitation in implementing such approach is that there is a since I come from a tertiary from a low and middle income countries group, there is a huge patient load, and the physicians don't have enough time to counsel them about the integrative management. And also there is a little resistance among the population about the holistic care, because it takes a lot of time and effort compared to just popping the medicine and hoping to get well. So this is my answer to the second question.
All right. Thank you for the feedback. Maybe a last one. From the different elements that you've described, mind and body therapy and diet and supplement, faith and religion, are these measures are they able to be used beyond metabolic syndrome, say in management of maybe neurocognitive disorders, or are they particularly limited only to metabolic syndrome? Maybe to hear your thoughts on the same.
Okay. Specifically, meditation and yoga has been associated with a lot of treatment of a lot of neurocognitive conditions and respiratory conditions. Meditation through breathing techniques can help in the treatment of asthma and respiratory illnesses. And through faith and religion, it was also found that a lot of patients showed a slower progression of the disease when they practiced faith-based management. So yeah, there are a lot of there are a lot of studies on those diseases that used yoga, tai chi, and a lot of those interventions. And meditate, yeah, alcohol. Okay, that's it. Just that.
All right, thank you. That's it from my end.
Thank you, Dr. Vincent. Now I invite Kavya to read the first question in the chat box.
Here goes the first question. What is the role of the PPAR gamma antagonist in metabolic syndrome?
PPAR gamma activates the lipoprotein lipase in the adipose tissue and helps in decreasing the levels of low density lipoproteins, thus helping in improving the lipid profile of the patient and improving one of the parameters of the metabolic syndrome, that is triglycerides.
Great, then let's move on to our second question.
What are the obstacles to implement integrated management?
Okay. The first obstacle is the lack of evidence among us doctors and the patients too. And as I mentioned earlier, the lack of time and efforts from our side and the patient's side, because of a very heavy patient load, we are not able to advise them in detail about the integrative approaches they could try. And just the lack of awareness in the public too. Like in India, there is very much importance of yoga and meditation, but about all the other interventions, there is very little knowledge. So that could be addressed through awareness programs, through newspapers, through us doctors, educating the patients and spreading general awareness.
Okay, then let's move on to our next question.
Yeah, it says like how relevant are the findings of your review in the Indian TNBC population?
I'm sorry, I didn't get the question. Can you repeat it?
Like, yeah, how relevant are the findings of your review in the Indian TNBC population?
Kavya, I think that question is for me.
Yeah, I think because it was put in the chat box, like there are many questions.
Okay. So do I need to answer it now or towards the end? How does it work?
No, that's okay for now. It's okay. No need to worry about it. That's okay. And the time for audience round is also over. Thank you, Kajal. Let's move on to our next participant. I would now like to invite our next participants, Dr. Rabi Tariq and Dr. Bhavya Kansal, to present their poster. Audience, you can put up your queries in the chat box. I would request judges to start the evaluation process. You can start with the presentation.
Hi, my name is Rabi Tariq and I am from Pakistan. Our topic of presentation is factors affecting transcranial direct current stimulation in Alzheimer's disease patients, a systematic review. So I will be continuing with the introduction to the initiation of results, and then Bhavya Kansal will be continuing from there. So Alzheimer's disease is the most prevalent form of dementia, and there have been several pharmacologic and non-pharmacologic treatments for this. And we already have no exact treatment for the cognitive decline, and there have been several attempts on that. One of those attempts is a brain stimulation or neuromodulation technique, which is transcranial direct current stimulation. It has been done in various sites of the brain, which I'll discuss later. So our objective was to identify the factors which are influencing the outcome of the transcranial direct current stimulation in the patients. So we use the PRISMA guidelines as a template for our methodology. And our mesh terms were transcranial direct current stimulation and Alzheimer's disease patients. So if our inclusion criteria was all the randomized controlled trials, case studies, case control studies, and all the studies which evaluate Alzheimer's disease patients and any other patients, including Alzheimer's disease patients, as well as case studies on the similar patients using transcranial direct current stimulation. The exclusion criteria was any study done, any study protocol or incomplete studies, any study done on pediatric similar patients or mild cognitive impairment, which is not exactly Alzheimer's disease, which is in initiation. It is the start of Alzheimer's disease. So we searched through PubMed, Cochrane Library, and Science Direct. And after removing the duplicates and screening, we were, after going through the whole PRISMA flow chart, we were left with 14 articles. And we added a few case studies as well. So for the evaluation of our results, we did a qualitative analysis of our results. And firstly, the first thing we checked was what exactly was the cognitive status of the patients after the transcranial direct current stimulation. So we saw that several studies reported that there was a significant change, and several studies reported that there might have been a change, but it was not significant. So as the studies were heterogeneous, we assessed what exactly was leading to this change, and we assessed the factors that influenced the outcome. So firstly, we saw that the positioning of the electrodes, especially on the left dorsolateral prefrontal cortex, it led to significant improvement in several studies, but it wasn't consistent. However, we can correlate this anatomically as DLPFC or dorsolateral prefrontal cortex is mainly involved in cognition. Then temporoparietal lobes stimulation resulted in improvements as well as DLPFC. But there were no significant changes in other areas of the brain, such as inferior parietal lobe, bitemporal and bifrontal lobe, left frontal parietal lobe, etc. If Bhavya would like to continue.
Yeah, so we studied a lot of factors that influence the effect of of transcranial direct current stimulation on the therapy outcomes, and the extensive factors that we studied extensively were the area of stimulation and the stimulation polarity. So there were a couple of studies that suggested, like there were even meta-analyses that were conducted on this particular topic as well in the past, and they said that, like, they concluded that anodal transcranial direct current stimulation is a much better method to stimulate the brain, and like the other methods like the dual current stimulation or the cathodal stimulation, they are not as much effective. However, when we conducted our review, and we found that the dual stimulation and the cathodal stimulation also have effects on certain parameters. So that is a main conclusion that we drew from our review, that we were studying the effects of certain factors in depth. Now, we found that overall cognition might have improved after anodal stimulation, and that is like corroborating the previous articles as well. However, it is also improved by dual stimulation. Dual stimulation is anodal and cathodal stimulation at the same time. So there was a study wherein the author had conducted bilateral stimulation of the dorsolateral prefrontal cortex, and it had concluded that this overall cognition, which we measured via MMSA or the standard tests like clock drawing test or ADAS-COG, all these had showed improvement from the baseline. Another conclusion that we drew in our study was executive function was improved after anodal stimulation in many studies. So that was one important area that came out, and it's a key factor, like it's a key study topic that can be taken up in future. Another one was a placebo effect. There is a powerful placebo effect that we saw because there were studies that had shown improvement in scores from the baseline in all three groups, which had a dual stimulation group or a cathodal stimulation group and a sham group. So placebo stimulation also showed improvement. So again, this is an important future study area. Another key factor that we were studying was the area that was stimulated. So generally, like the frontal lobes are impacted early in the course of Alzheimer's disease and mild cognitive impairment. So if when we were reviewing our data, so we saw that the dorsolateral prefrontal cortex, especially on the left side, has been studied extensively. However, what we found that was only 28% of the cases, like 2 out of 7 studies, had reported overall cognition improvement. And there was a particular finding that we had arrived at, that is when we compared it with the bilateral temporoparietal lobe stimulation, it also showed improvement. So, and more studies are needed in this regard, as in the data is already expensive for DLPFC, whereas another key area that can be studied is the bilateral lobes of the temporoparietal area. And we also studied about training, and training has shown a very, very positive effect in our review. And we strongly suggest that there are future studies that focus on this more, because there was no study that had training as such as a different group. Because if training was given in the study, it was given to all three groups, like the sham and the anodal stimulation group. They both had training. So training of what sort? As in working memory training. that is focusing on cognition or the memory or the verbal fluency. So that was one thing, and this actually masked one of our results in a study. So basically, when we were studying about nodal stimulation of the dorsolateral prefrontal cortex, one study had masked this effect because there were no group differences that we could that could show that nodal stimulation is the only factor that had resulted in the particular improvement in the outcomes. And another factor that we studied was a functional neural state. So systematic review had concluded that the effects of transcranial stimulation are significantly better for patients with mild to moderate cognitive decline. A possible hypothesis has been stated that the loss of neurons can be resulting into the loss of effect of transcranial stimulation for this. And we observed that no peculiar changes could be attributed to the variable length of interval between the sessions during the stimulation sessions. So yeah, this is also corroborated by a meta-analysis as well. And there were other limitations in our study because we had just 15 to 20 studies and like 15 trials and 4 or 5 case studies. So there was a lack of data that we could synthesize, and there was a lot of heterogeneity of the clinical trials. So we would want to pitch forward like more studies come up on this topic because it's a very promising promising therapy, and that's what we conclude, that it's well tolerated therapy as well because there were no adverse effects that we could review in all the articles. So it could be a future prospective therapy that can be taken into consideration. That's all.
I would now like judges to ask questions to Dr. Abid Tariq and Dr. Bhavya Kansal.
Thank you again for the presentation. I'll just have one comment and one question. For the question lies in the choice of focusing particularly on transcranial direct current stimulation as compared to the other modalities of treatment for Alzheimer's. So maybe you can just take us through what informed the choice of focusing particularly on this review on transcranial direct current stimulation. Then maybe the other comment will be, as I'd mentioned in the earlier presented systematic review, often it's very important to include an assessment of quality analysis for the articles included. And I'll be sharing a few resources on tools that you can use to include that before you proceed on to publication. So maybe you can just respond to that one question from my end, and then we'll get the other questions from the rest of the team.
Thank you for your question, Dr. Vincent. So for the treatment modalities of Alzheimer's disease, for your first question, we don't have an absolute treatment for Alzheimer's disease. Although we do have a drug named aducanumab, which is used just for disease modification, and it's also in trial. And we don't have a lot of treatment options for the cognitive impairments. So neuromodulation, specifically transcranial direct current modulation, is foremost one of the most promising therapies for reducing the cognitive decline. It can obviously not reverse the disease. It cannot do much about the tau and other protein deposits, but it can. There might, in some specific areas of the brain, in some specific types of, for example, anodal transcranial direct stimulation, it can lead to a significantly lesser cognitive decline in the current patients. Secondly, for I'm sorry, what was your second question? For assessment of quality analysis, right? Yeah. So as we had a lot to report, we did not report our quality assessment tools. We did use some quality assessment tools. We used consort guidelines for randomized controlled trials. We used stroke guidelines for observational studies and care guidelines for case reports. That's about it. I hope I answered your questions. There's another question in the chat box about what are the challenges in assessing the transcranial direct stimulation effects in Alzheimer's disease. So our whole paper was mostly about the challenges because there's a lot to add to this whole topic because direct stimulation can be in a lot of types. There may be it can be magnetic stimulation or direct stimulation. It can be anodal and cathodal. It can be in any part of the brain. It can be in parietal lobe, frontotemporal lobe, etc. So the main challenge is to identify that what exact type of stimulation is leading to the most significant impact on the cognitive status of the patient. I hope it answers the questions. If Bhavya would like to add anything.
No, Ravi, thank you.
Thank you, Dr. Vincent, for the questions. Kavya, is there any other questions left in the chat box?
No.
Okay, thank you, Dr. Rabi Tariq and Dr. Bhavya Kansal. Now let's move on to our last participant for today. I would now like to invite our last participant, Dr. Sunil Shahi, to present the poster. While the presentation is going on, audience can start asking questions as soon as the participant starts the presentation. I would also like to request the judges to enter the marks in the judge sheet. You can start with your presentation.
Good evening, everyone. I'm Dr. Sunil Sahi, a graduate doctor from Nepalese Army Institute of Health Sciences, Nepal. Expressing my sincere gratefulness to ISCI and PRMP team for this opportunity, I would like to start my poster presentation on a case report, tuberous sclerosis in a 16-year-old female. Tuberous sclerosis complex, it is a rare multi-system disorder that can affect many organs of our body, like skin, kidneys, brain, lungs, heart. And although it is believed that it is inherited in an autosomal dominant fashion, the majority of the cases do not have the clear family history, and there is a spontaneous genetic mutations. Our study mainly highlights the importance of genetic and clinical diagnostic criteria in identifying this rare condition, and also the role of regular surveillance in preventing future complications. So our case report was of a 16-year-old female who first presented with flank pain, and after a year later, she also presented with blood in urine. On examination, she had multiple hypopigmented macules over the back, right upper and lower limb, which are also known as ash-leaf spots. And there was also a palpable mass over the right lumbar region. There was also presence of saccharine patch and angiofibroma over the face. In laboratory diagnosis, the main significant finding was low hemoglobin, which was about 5.6 gram per deciliter, so that she presented with extreme fatigue at the clinic. In CT scan of the abdomen and pelvis, there was a 10.4 into 6.6 centimeter heterogeneous enhancing mass lesion in the right kidney with some areas of hemorrhages and fat densities that is also present in the figure A at the right kidney. And there were also multiple cystic areas in the same kidney. In the MRI of the brain, which is present in the figure B, there were multiple cortical and subcortical hyperintensity in the white matter, radial bands, and there was also presence of subependymal hematoma. We can see just adjacent to the ventricle in the figure B. there are subependymal growth, which are hematomas, and also there are hyperintensity that are spread throughout the cortex and and the white matter as well. And after the diagnostic workup for tuberous sclerosis, she was diagnosed with the condition as per the National Institute of Health Conference criteria. She was then admitted for symptomatic management of pain and anemia, and the patient has been under regular follow-up since she was diagnosed with this complex. So this tuberous sclerosis complex, as we already discussed, is a neurocutaneous syndrome that are basically diagnosed as genetic or clinical criteria. It is based on the second International Tuberous Sclerosis Complex Consensus Conference 2012, which have been updated in 2012. There were no any changes in the genetic diagnostic criteria, while there were slight changes in the clinical diagnostic criteria. In major criteria, multiple cortical tubers and radial migration lines were added in major criteria, whereas in minor criteria, sclerotic bone lesions were added. So as per the genetic criteria, there can be presence of inactivating mutations at either TSC1 or TSC2 gene, which codes for tuberine and hamartin protein in the normal tissue. So these pathogenic mutations are required for the genetic criteria, while in the clinical criteria, there are major and minor criteria. To fulfill the definitive diagnosis criteria, there should be two findings from the major criteria, or one major and two or more from the minor features. And for a possible diagnosis criteria, there can be one major or two or more from the minor criteria. In major criteria, the clinical features, it includes hypomelanotic macules, angiofibromas, ungual fibromas, shagreen patch, multiple hematomas, multiple cortical tubers and radial migration lines, subependymal nodules, subependymal giant astrocytoma, cardiac rhabdomyoma, lymph angioliomatosis, shortly LAM, angiomyolipomas. In our patient, she had 5 major clinical criteria, which includes hypomelanotic macules, angiofibromas, shagreen patch, subependymal nodules, and angiomyolipomas. And in minor criteria, it includes confetti skin lesions, dental enamel pits, intraoral fibromas, retinal achromic patch, multiple renal cyst, non-renal hematomas, sclerotic bone lesions. In our patients had 2 minor features, clinical features, which included multiple renal cyst and sclerotic bone cyst. So since our patient had more than 2 major criteria, including the 2 minor criteria, she was diagnosed as tuberous sclerosis based on clinical criteria. And after the diagnosis, she was confirmed. She was advised for regular surveillance along with the early intervention as required. And in case of tuberous sclerosis, after the diagnosis, we suggest MRI of the brain and abdomen done every 1 to 3 years. And we also recommend annual dermatologic examination along with yearly assessment of the renal function. Likewise, annual examination to look for tuberous sclerosis complex associated neuropsychiatric disorders, as well as EEG for suspected seizure disorder. And also we suggest for screening that are required in cases of eye, heart, and teeth and lung. For eye, we can do fundoscopy examination, heart, ECG, and echo. For teeth, we can also do yearly dental examination. So concluding this case, tuberous sclerosis, it is a very progressive course, so that we need to do regular surveillance of this patient to prevent debilitating complications that might develop in the future. And early diagnosis with the help of genetic or clinical criteria is very important with regular surveillance. of different body systems, as just mentioned above, to prevent these debilitating conditions. Thank you. If you have any questions, please, I will be happy to answer your questions.
I would now like judges to ask questions to Dr. Sunil.
Thank you for the presentation. my question will be in light of the associated genetic history or genetic predisposition to the disease, were you able to obtain or identify any family history that was linked to the current presenting case? That's my first question. And then probably secondly, would be to inquire on whether all right. I think actually I've asked the second question through the first one. Yes. So just my question particularly is, were you able to determine the family history in light of the genetic predisposition?
Okay. Talking about genetic history. Genetic history, though it is commonly present as autosomal dominant, it is not always present. It is only the genetic mutations. These only allow for only 10 to 15% of the cases, and most of the majority of the cases, there are spontaneous mutations. And in our case, there was no family history. The family had no any clinical symptoms suggestive of tuberous sclerosis. Due to the unavailability of the genetic testing, the genetic testing was not performed on the parents. Actually, after a diagnosis of every case, I mean, especially in a child, because this condition usually presents in a child, diagnosed in a child. After the diagnosis of a case, we usually recommend genetic testing of parents as well, just to ensure, just to confirm that whether it is inherited from the parents or not. In our case, our patient was diagnosed based on the clinical criteria. We had no genetic testing facility available at that condition, so we did not perform the test in the parents.
All right, thank you for the response. Maybe the last thing would be, apart from the rarity of the condition, is there anything else that probably you'd mention that would highlight on the uniqueness of the case that you present to us? Or is it generally centered around the rarity of the condition?
In this, as already said, this is a rare condition. Also, this is a progressive condition. Many clinical features can develop in the future, as well as the severity can also vary among the cases. Some might have only dermatological manifestations, while the other present with severe cases involving the neurological system or the other systemic manifestations involving the heart, kidney. And so, since this is initially the patients only have few symptoms, and they go on to later develop other symptoms during their course of illness, which the main importance of our case is after the diagnosis is regular surveillance, so that detecting and treating as required would be the most favorable course of action in the management of this tuberous sclerosis case.
All right. Thank you. That's it from my end.
Okay, thank you,
Dr. Vincent. Thank you. Now I invite Kavya to read the first question in the chat box.
Yeah, here goes the first question. Though you have mentioned the criteria to diagnose tuberous sclerosis, what would be the differential diagnosis in this case?
In the differential diagnosis, since this is a phacomatosis, I mean, this is also one of the neurocutaneous diseases. The other neurocutaneous diseases can also be in the differential diagnosis. For example, neurofibromatosis or that von Hippel-Lindau disease. But basically, this is more distinct features. We not only need one major clinical criteria, we also require several clinical criteria that are more specific to this condition. We basically go with the criteria as I outlined before, to definitely diagnose this condition as a tuberous sclerosis. However, if there are only few symptoms, for example, only skin manifestations, then diagnosing this condition can be pretty difficult if there are only one or two symptoms, since we require two major symptoms for the diagnosis. Yeah, so if there are few symptoms, then other neurocutaneous syndromes can be in the differential diagnosis. Thank you.
Okay, then let's move on to our second question.
No, this was the only question. You can move.
Thank you, Dr. Sunil. And this marks the end of the poster presentation competition. Yeah, okay. I really want to mention this, that I'm left astonished at the level of dedication and hard work you participants have put into this competition. I really appreciate your efforts. May you all reach every height of success. Thank you all the participants, and special thanks to judges and audience for their invigorating questions. Till the results are being calculated for this competition, I would now invite Dr. Purva Shah, founder and president of ISCI, to take over.
Thank you, Lalita. I do agree with Lalita when she says that it was an amazing poster presentation. I would like Vincent also to share with us how he felt about the poster presentation.
Wow, thank you so much. And I think first, even before I comment about the posters, it's such an amazing work that the society is doing, especially being not having been in existence for quite a long time. It's quite some significant progress that you've made, especially in furthering research and from the quality of presentations that we've had today. It's quite clear that you guys are really having quite some impact in both locally and even globally. Yeah, so a huge and hearty congratulations to the entire team and to the presenters today. It's quite amazing the quality of work that you're presenting, and of course the impact will be felt even as you move forward to the next phase to publish your papers. And I'm really impressed by the quality of work, the novelty of the findings, and even more importantly, just how well enough each of you had integrated the background and even presented your findings in respect to the different papers that you presented today. So my general comment is you guys are doing a great job, especially for a start. And with the same trajectory, you can only go further. So congratulations to the team and to all the presenters. Thank you.
Thank you. Thank you so much, Dr. Vincent, for such motivating words. And I'm happy that we were able to live up to the scientific standard that is going on in the world of research today. Thank you. Okay. So now moving on to the next session of today's event, the Prmp Awards and the World TB Day 2022 Competition Awards. I will first announce the results of Prmp Awards of August to December 21 rotation, which was the first Prmp rotation, and it included 130 researchers spread over 20 groups. Prmp Awards are a way of motivating the researchers to work sincerely in their respective groups and proactively completing all tasks assigned to them. It is important to know that your work will not go unnoticed because Prmp leadership conducts regular quality checks and monthly updates to quantify the effort of all the hardworking researchers. The Prmp Awards are divided into 4 categories: Best Mentee, Mentor, Research Project, and Prmp Group. May I ask Vicky to please share his screen so we can have a look at all the winners? Great. Thank you. Next slide, please. So this is about the August to December 21 rotation. Can we move to the next slide? Yes. So first award is Best Mentee Award. The criteria for judging with this particular category were these 9 points: interest in taking responsibility for the group, attendance in group meets and phone calls, latency in responding to text messages and emails, ability to meet deadlines for tasks, ability to grasp new information, number and type of published papers, number and type of papers presented in conference, mentorship role in a future PRMP rotation. So if the mentee turned into a mentor in another rotation, like the Jan to June 22 rotation, then that was also taken into consideration. And the 9th point was interest in taking leadership role. So we can see the strong contenders in the next slide. Here you go. So we have Bhavya Kansal, Ziba Sami, Rama Al-Khali, Anusha Qureshi, Amna Siddiqui, Vidhi Parekh, Alishba Adnan, and Yashjot Kaur. So most of these mentees are now working as PRMP mentors. This is a strong advantage that sets them apart from their colleagues. Also, most of these researchers have a publication or presentation by their name that they worked on during their PRMP tenure. They are all proactive when it comes to taking responsibility for the group and also make sure that their fellow mentees are able to complete their work on time. During mentor meets and group update sessions, mentors of all the PRMP groups provided names of some mentees whose quality of work was a class apart, and these names stood apart. So, moving to the winner of the category is, could we have the next slide, please? Best Mentee Award goes to Rama Al-Khali. So Rama is a third-year medical student from Syria and Canada, studying at the Royal College of Surgeons in Ireland. She belongs to PRMP Group 0115 with Dr. Surbhi Chatterjee as her mentor. She was one of the first PRMP mentees to get a publication and conference presentation. Under Dr. Surbhi's guidance, she was able to publish a commentary titled Implications for the Future of Obstetrics and Gynecology Following the COVID-19 Pandemic. The group also published an abstract of their systematic review, which was based on diagnostic performance of a range of available novel machine learning. She also presented her group's paper at a poster presentation conference held by Royal College of Physicians, Medicine 2022. She has taken up the role of mentorship of Group 0 to 12, that is the group of Jan to June 2022 rotation of PRMP, and her papers in the new group are already ready for submission to journals. I would also like to add that Rama takes initiative to come up with solutions to problems that she thinks may improve the quality of PRMP research program. Congratulations, Rama. I would like to invite Rama to give an acceptance speech if she's present in the Zoom call.
Hi, can everyone hear me?
Yes, Rama.
Okay, perfect. First of all, thank you so much, Purva. It's truly an honor to have received this award. I'd just like to say, none of this would not have been possible without the ISCI program, the PRMP program. I remember last year in the summer, I was just scrolling through LinkedIn. I was frustrated with my old research supervisor who wasn't taking me seriously. And I saw Purva's post about the PRMP program, and I was so excited about it. So right away, I registered. And now a year forward, I've gotten 2 posters, 2 publications, 1 abstract, and I have 2 submitted publications. So I have received a lot of help from a PRMP, and I'd like to thank my mentor, Dr. Chatterjee, for her immense support throughout the whole process. And I'm so grateful for this program. It's truly an amazing initiative. And I hope to everyone listening, my biggest advice is to not give up. If you're not finding research opportunities, if you're getting rejected, just keep at it and don't be afraid to ask for help. Research is a team effort. So thank you so much, Purva. It's truly an honor.
Thank you, Rama. Thank you so much. I'm glad you had a great experience. Okay, now moving on to Best Mentor Award. Thank you. The criteria for judging for the Best Mentor category were these 9 points: interest in creating learning material for the group, ability to create a timeline at the beginning of rotation and then adhering to it, latency in responding to text messages and emails, attendance in mentor meets. So these are similar to the categories for best, the criteria for best mentees, I'm sorry. The fifth one is interest in teaching each step of research and allowing independent thinking in their group. Then we have the number and type of published papers, number and type of papers presented in conference, number of their mentees who became PRMP mentors. So this was also an interesting point. If they were able to teach properly and mentor and guide their mentees, the mentees eventually turned capable of independently conducting research studies and even teaching future mentees in the program. And the last was interest in taking leadership role in PRMP. Can we have the strong contenders for this award, please? So the contenders are Surbhi Chatterjee, Rabi Tariq, Mehul Sinha, Pratyush Kumar, Rahul Mittal, Aman Javed, and Asan Rakib. After reviewing PRMP mentor sheets and checking the work of all mentors in their respective WhatsApp groups, these selected names stood out. On conducting anonymous quality check sessions, most mentees from their groups were very happy with the progress of their projects. In addition to teaching all the steps needed to independently conduct research, these mentors have the ability to lead their mentees to a successful publication and paper presentation. Let's have the winner of this category. So Best Mentor Award goes to Mr. Aman Javed. Talking about Aman, he is a medical student at University College of Medical Science and Guru Tegh Bahadur Hospital in India. He belongs to PRMP group 0105, and his group has published a systematic review on association between mesenchymal stem cells and COVID-19 therapy. His group has also published a letter to editor related to traumatic brain injury in COVID-19 patients. Another paper, which was also a letter to editor, was titled Postmenopausal Women, Estrogen Levels and Relation with Cognitive Deficiencies in Alzheimer's. This paper is under review for publication. Aman, along with 3 mentees from his group, presented their paper on the occurrence of pruritic urticarial papules and plaques in multiple pregnancies at the CIPT Obstetrics and Gynecology Conference in 2022. 3 mentees from group 0105 have taken up the role of mentorship in January to June 22 rotation. Aman recently joined the PRMP leadership also as the regional project head of India. As regional project head, his work is meticulous and he believes in completing all the work as soon as he is assigned a task. Aman is also one of the co-authors of a multi-centric study under the TRCCI banner of ISCI. Congratulations, Aman. I would like to invite Aman to give an acceptance speech, please.
Thank you, Purva, for such high motivation and a praise. I'm really glad to receive this award. Apart from that, I really do remember when we first started working on the Abdominal project. And since then, we have come a long way, ICSI and the multi-organization study. So I'm really glad, and also thanks to you, thanks to all the organizing team and the mentors who worked really hard with me in doing all the projects. So hoping to continue the same success in the remaining projects which we are having, and also looking forward to working on more projects with you. Thank you.
Thank you so much, Aman. Thank you. And now we will move on to the best research project. Can we move to the next slide, please? Yes. The criteria for judging for the best research project were quality of evidence as per evidence-based medicine pyramid, originality of research topic, timely completion of the project. This was very important. Impact factor of journal where the paper was published, quality of conference where paper was accepted. So either or, we took either journal or the conference. And let's have the strong contenders for this particular category. So the first contender would be group 0105. and they have 2 letters to editors, 1 letter to editor, 1 systematic review, and 1 paper presentation at a conference. Let's move on to the next category, please. Next contender, please. Sorry. 0115. Thank you. So 0115 has multiple paper presentations. Example is NANSIG, SBNS. We have Oxford Research Summit. We have Royal College of Physicians Medicine. We have European Association of Neurology. We have European Association of Neurosurgery Conference, and the other conferences where they were selected. They have published an abstract on their systematic review. They have published 2 letters to editors, and they were one of the first groups to have completed their project. Moving to the next contender, group 0104. So they also have an e-poster presentation in their bag, and they presented it to the International Neuromodulation Society, the 15th World Congress, which will be held in Spain. And the winner of this award is next, group 15. So group 15's mentor is Surbhi Chatterjee, and the mentees are Deepak Bethinidhi, Pragya Yadav, and Rama Al-Khali. Congratulations, Surbhi, Deepak, Rama, and Pragya. Your projects were the talk of the town in PRMP groups, as these were one of the first ones to be completed and published. I would like to invite the group mentor, Dr. Surbhi Chatterjee, to give an acceptance speech if she's present in the Zoom call. I can see Surbhi's name. Okay, she's, I think she has left, no problem. Moving to the next category, the best PRMP group. The criteria for judging the best PRMP group were these 8 points: combined effort of mentors and mentees, communication between members, feeling of belonging to the team. Some soft skills were also measured, ability to adhere to the group timeline, equal participation by all group members, number and type. So these 3 were similar in all the categories: publications and presentations, and also very important, number of mentees who turned into mentors in a future PRMP rotation. So let's have the contenders. We have these 3 contenders. 04, Rabi Tariq is the mentor of this group with Bhavya Kansal, Saroja, Ramin Sheikh, Seema Bista, and Shriya Datta as the mentees. This group is also very strong and very well knit, and the feeling of being one in a team is very strong in this particular group. Coming to the next group, 0105, we have Aman Javed as the mentor, and the mentees are Anaka, Shri, Anushka Arora, Vicky Kumar Sa, Jayashri Batis, Jasneet Kaur, Sara Saxena, Saurabh Karki, Shankhnil Ghosh, Sucharu Asri, Ziba Sami, and Suha Khan. These are the first ventures of the PRMP program. They are go-getters, and they, I think, have a type A personality, and they want to achieve it all. They are very fast in their project, and I usually see their proceedings, and it's really, really impressive how everybody puts in their effort. And now coming to group 0115, we have again Surbhi Chatterjee as mentor, Deepak, Pragya, and Rama are the mentees. So these are very, very strong contenders for this particular award category. And moving to the group that won this award, Best PRMP group goes to group 0105. I extend a hearty congratulations to the entire team. I invite one of the mentees from this group to talk about their experience working in PRMP and also about their mentor, Mr. Aman Javed. So any one of the mentees, if you're there, I think Anaka is here, Vicky is here, Saurabh is also here. So I invite one of you to please talk about your experience.
Hello.
Hi, Anaka. Hello.
Hi.
Congratulations.
Thank you. I've had a really good time with everybody, especially our mentor, Aman, and all my mentees. Everybody has been very punctual. And Aman, as a mentor, has done a really good job. He's very punctual and orderly, and he explains things very well in such an easy manner that you're able to understand. And as a whole, the group is very transparent. So people get to know very quickly. As you said, it's very steady group. As far as PRMP, this program was concerned, I feel like everything went very smooth, and it was very well organized. And the meetings were also conducted very often. And overall, I was very satisfied with the whole research project and my team. So kudos to all of us.
Thank you, Anaka. Yes, for sure. Kudos to you all. And all right, so congratulations. Congratulations to all PRMP mentors and mentees of the August to December 2021 rotation for a successful completion of their projects. Now, I would like to share with you the results of the World TB Day 2022 competition that was organized in March earlier this year. This competition marked the beginning of our tuberculosis program called Lysis of the TB Crisis Program. Congratulations to all winners. Let's have them. Next slide, please. Thank you. So this was the competition that was held on the online platform. Can we have the next slide, please? So we have Dr. Gnan Deepti, who won the poster presentation competition called Pathology Pictorials. I invite Dr. Deepti to please give her acceptance speech.
Hello, everyone. This is Deepti, and firstly, I want to thank Dr. Purva and all the ISCI team for organizing this competition and also this conference. I'm really very happy to say that I won this competition, and also this conference was very organized and it's really awesome. I didn't expect this, but it's really awesome. Thanks, Purva. And also, I wish you conduct this in a type of conferences and also the competitions the following year also. And thank you, Purva. That's all.
Thank you, Deepti. Wow, I got so many thanks. I would like to just point out, I'm just a spokesperson. The whole organizing team did a tremendously wonderful job, not just for this tuberculosis program, but for the annual conference also. And also the people working in the PRMP leadership who took the time to get monthly group updates and the quality checks. So it would not have been possible with a strong team. So kudos to the team, I would say. But thank you, Diti. Thank you so much. You're very sweet. Let's move to the next category, please, of the TB competition. So we have Dr. Shashikant Saini, who won the essay writing competition called Words Worth Sharing. Congratulations, Shashikant. I invite Dr. Shashikant to give an acceptance speech, please.
Yeah, hello. Can you guys hear me?
Yes.
Hello.
Yes, we can hear you.
Yeah, hello. Hello, everyone. I'm really sorry. Actually, I'm in a function right now. So first of all, I want to thank Pua for giving me this opportunity and the ISCI for this organizing this essay competition, and by which I got to know so many wonderful people, Dr. Lalita, Dr. Himanshu, Dr. Puneet, and I'm sorry I couldn't attend this conference, many of the sessions of this conference. I'm really sorry for that, and I hope we will work on many projects together in the future. Thank you, everyone. I'm so sorry for the inconvenience and all the noises.
Not at all, Shashikant. Thank you for coming here and coming from your function and giving this speech. Thank you for that. And I would like to tell all of you that Shashikant and Deepti, they are the leaders of the tuberculosis program of ISCI, and they are doing a great job at creating the TB information portal. The team is very hardworking. And now moving to the next category, video making competition, Speak Your Mind. And the winner of this competition was Dr. Samyam Bikram Pathak. Dr. Samyam is going to join us from the next rotation onwards. So excited to work with him. Okay, so I think we are done with all the winners. So congratulations to all the winners. About results of today's competition, the organizing team and I will calculate Dr. Vincent and Dr. Bharati's scores, and we will be able to give you the results after the weekend. So you will have to wait for it. Apologies for that, but the scores will be out very soon. All right, so now I will invite Lalita to extend the vote of thanks.
Thank you, Dr. Purva. We are happy and grateful to our judges, Dr. Vincent Kipokir and Dr. Bharati Gadad, for sparing their valuable time with us and gracing this event. Thanks to all the members of organizing team, Dr. Purva Shah, Dr. Suganya Karikaran, Mr. Aman Javad, Mr. Biki Kumar Shah, Mr. Abhay Srivastava, Ms. Shruti Koduri, Mr. Yashwanath Manchukunda, Ms. Kavya Shivaprasad, Dr. and Dr. Ananya Dubey, the hands that contributed for success of this event. Attention spans of such length are rare in our field. Indeed, we can't thank you enough for giving this conference such massive attention. Cheers to our audience. Once again, I would like to thank each and every one of you and take your leave with a grateful heart.